Well, thank you very much, Ben. It's a great pleasure to participate in this conference. And what I'm going to talk about is inhaled drugs for COVID-19, which of course is caused by a respiratory virus. So these are my potential conflicts of interest. So I think people are very aware now of the background to this presentation. So SARS-CoV-2 is a novel coronavirus which infects the upper airways and in particular invades epithelial cells. And it spreads from the upper airways to the lower airways, and it can spread to the lung periphery where it selectively infects type 2 alveolar cells, and this may lead to a severe form of pneumonia, and it may spread into the circulation, giving a systemic inflammatory response and multi-organ failure. And it's important to recognize that the virus is spread, as are other respiratory viruses, by droplets and aerosols. So this is a progressive disease, and it starts with a viral infection of the upper airways, and that leads to local symptoms, nasal symptoms, sore throat, and anosmia as the virus infects olfactory nerves. It may then spread down the respiratory tract, causing cough, shortness of breath, and hypoxia. And then it moves into the inflammatory, hyperinflammatory phase with a cytokine storm, which is associated with acute respiratory distress syndrome, and then eventually multi-organ failure, which may be fatal. So if we're going to use inhaled therapy, it would be most logical to use it in early disease during the viral and early inflammatory stages. So if we think about inhaled therapies, we want to target early disease, which we define as less than 7 days from the onset of symptoms. We need to have a rapid onset of effect to prevent the disease progressing, and this is achieved by directly targeting the site of infection. It should be a treatment that is rapidly available so that treatment can be easily started quickly in the real world. So you don't want to have delays of having to get doctors to order something which is not readily available. And it needs to be something that's safe because it may be applied to large populations. So what we would expect from an effective inhaled therapy against SARS-CoV-2 virus is that we could reduce progression and in particular prevent hospitalizations and death. We may also hope to prevent the long-term sequelae of this disease, sometimes known as long COVID, which may be due to persistence of the virus and may be seen even in people who have relatively mild disease. We may also hope to reduce or prevent disease transmission by reducing the viral load and therefore the amount of virus that people breathe out to reduce community transmission. So what we're looking at in these inhaled drugs is either antiviral drugs or effective anti-inflammatory drugs that would work topically by inhaled delivery. And this may be achieved by repurposing existing therapies, and I'm going to give the example of inhaled corticosteroids, or we may develop novel therapies that can be given by inhalation. I'll give some examples of this at the end of the talk. So let's just look at the sequence of infection. So the SARS-CoV-2 virus is a single-stranded RNA virus, which also has structural proteins. Particularly important are the spike proteins on the outside of the virus, because these are what engage with receptors on epithelial cell surfaces, which then allow the virus to enter the epithelial cell. And key receptors for this virus are ACE2 and TMPRSS2, which are both highly expressed on human nasal and airway epithelial cells, and are very highly expressed on AT2 cells. Once the virus is bound to the surface of the cell, it's internalized, and then it translates the viral RNA so that it can reproduce in the cell and also produce non-structural proteins. And this means that you get replication of the virus within the cell. And finally, the virus is shed from the cell, usually by killing the epithelial cells. So this virus has a cytopathic effect. So initially, I think everyone thought that SARS-CoV-2 would have a particularly bad effect in people with asthma and COPD, because it was already well known that coronaviruses, such as SARS, are able to trigger exacerbations of asthma COPD. And the normal coronaviruses that trigger these diseases are the viruses that give common cold symptoms. So we expected that asthma and COPD patients would be particularly susceptible to severe effects of this virus. And yet, in the early reports from China and confirmed everywhere else in the world, asthma and COPD patients are greatly underrepresented amongst the people with COVID-19 who are hospitalized or who die. And the reasons for this are not clear, but one possibility is that the inhaled steroids that are commonly used by patients with asthma and COPD were in some way protecting against the disease becoming severe or reducing the risk of getting the disease. And so people started to look at what corticosteroids did to the way the virus infects the cell. And what you can see in these graphs is that corticosteroids markedly reduce the expression of ACE2 and TMPRSS2, which are the main receptors for the virus on epithelial cells, but have no effect on ICAM1, which is the main receptor for rhinovirus. So there does seem to be a reduction in the receptor, and that's confirmed by this in vitro study where human airway epithelial cells were exposed in vitro to a commonly used inhaled steroid, and you can see a marked suppression of ACE2 expression. So that may be one mechanism that's important, but there may be other mechanisms. So this study from Japan showed that inhaled steroids, particularly memetazone and cyclesinide, actually inhibited the replication of the SARS-CoV-2 virus in a cell line VERO-E6, which is particularly susceptible to infection by this virus. And the third effect that inhaled steroids have that we already knew about is that they inhibit the release of inflammatory cytokines from epithelial cells infected with virus. In fact, the studies have been done mainly with other viruses, but we know that inhaled steroids have a broad spectrum of anti-inflammatory effects, and that's how they work in asthma. So that led to us conducting a study of inhaled steroids in early COVID-19. And this is a study that was coordinated by Mona Baffadel in Oxford and was performed in general practices in Oxfordshire. So this was an open label study because this was during the time of the pandemic, and it was very difficult to do controlled trials rapidly because it takes a long time to get the matched placebo. So this was an open trial comparing a commonly used inhaled steroid, budesonide, at the maximum recommended dose with usual care. And the treatment was given twice a day, as is the normal way of delivering the drug, until resolution of the symptoms. And we looked at people with recent onset of symptoms, defined by symptoms within the last 7 days. And this was confirmed with a PCR test. And the primary outcome was to look at whether people went on to require urgent care. So in other words, we're looking at whether the inhaled steroid is stopping the virus from causing severe disease. So we had 140 subjects included, and you can see there was a wide age range in this study. The study was stopped early because of the monitoring committee thought there was such an important difference between the inhaled steroid and the control group. So you can see that only one patient on budesonide needed urgent care, whereas 10 patients in the control group required urgent care. So the number needed to treat to prevent worsening was only 8 people. It also produced a faster recovery of symptoms, and we also measured temperature, which recovered more quickly, and this was highly significant. It improved oxygen saturation, and there was some reduction in viral load after this treatment, although this didn't achieve statistical significance. So these results were quite promising, and were followed up by a second study in Oxford that was also an open label study because it was done early on in the pandemic, and looked at the same dose of inhaled budesonide given for 2 weeks in the community. So this was done in general practice throughout the UK. This is a larger multi-center study. And the key difference from the previous study is that it was done in people with higher risk of developing severe COVID. So these were people over the age of 65 or people over the age of 50 who had comorbidities such as obesity, diabetes, hypertension, which are known to increase the risk of severe COVID. So again, we looked at adults with recent onset of symptoms, and the primary outcome in this study was time to recovery. And in this study, you can see that, again, there was benefit from the inhaled steroid because you got more rapid recovery, on average around 3 days more rapidly recovering than the usual care control group. The number of hospitalizations were quite small. It was less in the steroid group than the control group, but was not statistically significant because probably of the low number that developed were hospitalized in this study. So these studies were encouraging. Now, this is going back to the Japanese study, which I showed earlier, where they looked at the effect of inhaled steroids on infection with SARS-CoV-2. And you can see that in terms of cytopathic effect, budesonide had some benefit, some inhibitory effect, but some steroids were more effective than budesonide, namely mometasone and ciclesonide. And here you can see in terms of antiviral effect by measuring viral titer that both mometasone and particularly ciclesonide have direct antiviral effects. So ciclesonide seemed to be the most effective of the inhaled steroids. And this has led to several studies with inhaled ciclesonide in COVID-19. This is one recently published study that was done in Canada, which looked at inhaled and intranasal ciclesonide versus placebo. So this is now a proper placebo-controlled trial. And basically, there was no difference in any of the outcome measures, which we're looking at clinical improvement between the ciclesonide and the control, which is disappointing. However, this study looked at young people. The age range was 27 to 45, so much younger than the age range of the studies that were done in Oxford. And these are people with a very low risk of developing severe disease. So it may not be an appropriate population to really study this, or you may need much larger numbers. I think there were about 100 patients in each group in this study. A very recent study that was published only last week, I think, is also a double-blind placebo-controlled trial with ciclesonide, and this is in a larger number of patients. And what you can see is that there was some reduction in the proportion of patients that were developing severe disease, although this was not really significant. But there was a reduction in severe episodes measured by ER visits and hospitalizations. This is a relatively small effect compared with what we saw with budesonide, but again, this is a young population that has a low risk, so it may not be a suitable population to study this effect. So this is something that still needs to be further investigated. And I think one of the important lessons is that we have to have very early introduction of the inhaled steroids for the best effect, which makes sense scientifically. So people are looking at other possible inhaled treatments for COVID-19. And this is a study that has been published with inhaled interferon beta. As you know, interferon beta is part of the innate antiviral defense mechanism, and interferon beta is produced by epithelial cells as a protection against viruses, and can be given, the rationale being that if you give more interferon beta, you may have a greater antiviral effect, because people that get severe disease may not mount a sufficient interferon response. So this was a study done in the UK that was a double-blind control trial looking at nebulized interferon beta that was given daily over 2 weeks. And it was the people had severe disease confirmed by PCR, but they were hospitalized with COVID-19. So a much more severe population than the previous studies I showed. and they'd been symptomatic for about 10 days by the time they were initiated with the treatment. And this study did show a convincing reduced time to clinical recovery, which was the main outcome measure. So they recovered twice as fast as the control group. And you can see that there were 3 deaths in the control group, but none in the active group, and the treatment was well tolerated. So this was quite an encouraging result. And further studies are now being done in larger populations, presumably phase 3 studies, including people with less severe disease. Heard any results yet? Because I think those trials are still in progress. There are other antivirals that are being considered for COVID-19. Niclosamide is an antiparasitic which can be used in humans, but has also been shown to have broad spectrum antiviral effects and is effective against SARS-CoV-2 in vitro. Also, oral niclosamide has been shown to have some efficacy in COVID-19. So this led to the development of an inhaled formulation, which is a dry powder form of niclosamide that could be given by inhalation or intranasally. And in a phase 1 trial, it was shown to be well tolerated in healthy volunteers and is currently in phase 2 studies in COVID-19. Remdesivir is well known as an antiviral that has activity against SARS-CoV-2, and systemic remdesivir has some clinical benefit in severe disease. But an inhaled formulation has now been developed, which involves remdesivir in liposomes. And so this is something that people are thinking about giving as an inhaled therapy for disease across the severity spectrum. Lastly, PAL42 is an inhaled agonist of toll-like receptors, and this has been shown to be very effective against coronavirus lung disease in mice. So a nebulized form of this is currently in clinical trial for COVID-19, but I don't think any results so far have been made public. So there are several antivirals in development for COVID-19. So in conclusion, SARS-CoV-2 is a respiratory virus which infects airway epithelial cells. So inhaled therapies are a logical approach in early disease to prevent disease progression and possibly to prevent long COVID and viral transmission in the community. Inhaled steroids are a logical treatment in early COVID-19 because we know steroids inhibit the binding of the virus, virus replication, and the early inflammatory response to the virus. And to date, there are 2 studies with inhaled ciclesonide that have shown increased recovery and reduce progression to severe disease. And this has been incorporated into guidelines for managing COVID-19 in several countries around the world. Inhaled ciclesonide seems to be the most effective anti-SARS-CoV drug in vitro, but so far clinical trials have been ineffective or relatively ineffective, but probably the wrong populations were chosen for these studies, and it's necessary to really study this treatment in people at greater risk of developing severe disease. developing inhaled antivirals is a logical approach, and nebulized interferon gamma looks quite promising for improving the recovery of people with severe COVID-19. And several other antivirals are in clinical development. However, the recent development of oral antivirals, such as molnupiravir and particularly Paxlovid, may reduce any need to look for inhaled therapies because it's much easier to take oral drugs. However, these antivirals may have resistance, and so they may not be as effective in early disease as an inhaled drug, and more studies need to be done. But the very encouraging preliminary results with Paxlovid really look as if this might obviate the need to develop inhaled therapies for COVID-19. So thank you very much for your attention.
Thank you very much, Peter, for that very nice overview of where we've got to with inhaled therapies. So time for just one or two questions, I think. Gary, you want to start?
Thank you, Peter. Well, as always, there are a few questions. There's, I think, quite an interesting one here from David Ferguson. Do you have any thoughts on why COVID-19 appears to be so much more severe in adults than in children? Could it be related to differences in the inflammatory response in the two populations?
Sorry, Gary, I didn't hear the first part of it. It just went. Oh.
Sure. Okay, I'll repeat it. No problem. Yeah. Do you have any thoughts as to why COVID-19 is much more severe in adults than in children? Is it, or could it be due to a difference in the inflammatory response between adults and children?
Well, we have a theory that severe COVID-19 is due to cellular senescence, which is more common in elderly people. And we've actually shown that the SARS-CoV-2 induces senescence, and that these senescent cells release inflammatory mediators. So children would be less likely, I think, to develop senescence with this virus, but that's speculative. We don't really know the answer.
Okay, that's good. Thank you. Ben?
Yeah, Peter, is there a place for inhaled corticosteroids in prophylaxis, perhaps in high-risk individuals?
That's a very good question, Ben, and I don't know the answer, but I think that there's a potential place because these treatments are very safe and relatively cheap. I mean, much cheaper than the other treatments developed for COVID-19. So I think there is a place. I mean, not as good as vaccination, obviously, but I mean, in combination with vaccination, maybe there is a place in high-risk groups, and maybe that's the very reason why these patients with asthma and COPD have much less severe disease. So I think that's a very good point, and something that could be studied. In a way, that's what we did, trying to look at early disease, but I think you're suggesting giving it to anyone that's at high risk to protect them, and I think that's something that could be looked at.
Peter, there's a question here. It says that we seem to be relying on repurposing drugs, which is quite logical given the urgent need. But in your opinion, are there any new drugs which will offer better treatment options?
Well, yes, and I think those are the drugs that eliminate senescent cells, known as senolytic drugs. There are very, very impressive results in an animal model of coronavirus, which is in mice, which is very similar to COVID-19, although it's not exactly SARS-CoV-2, which doesn't infect mice. And the results show a striking efficacy. So I mean, I think for severe disease in the future, we may look at treatments that target senescent cells that harbor the virus. And what we've shown is, what is known is that senescent cells persist and they release pro-inflammatory cytokines, and they spread senescence to other cells, either through the inflammatory cytokines or through vesicles, as we've recently been able to show. So I think that targeting these senescent cells that are infected with the virus is a really promising approach. And we think that these senescent cells may also be the mechanism of long COVID, because they persist and would continue to release cytokines that can produce various long-lasting diseases. So I think that should be the priority for future drug development.
Thank you.
So many thanks, Peter. It's a hot topic and it'd be interesting to discuss it for much longer, but in the interest of time, we're 5 minutes over our schedule, and we're going to run ourselves into trouble if we're not careful. So thank you very much for your presentation, and I'm sure it's a topic we'll return to in the coming months and years.